Loratang Kgomotso from Norway. I have no interest in there. Yeah. Degenerative lumbar spondylolisthesis is the forward slippage of one vertebra relative to the one below. It's common in patients over 60 years of age, and with a concomitant spinal stenosis can give symptoms of back pain and radiculating pain to the lower extremities. There are two main surgical treatments if indicated, decompression alone or decompression with instrumental fusion. The Norway DS trial aimed to investigate whether decompression alone was non-inferior to the decompression with instrumental fusion. At the 2-year follow-up, the trial found decompression alone not to be inferior to decompression with instrumental fusion. Evidence supporting decompression alone is becoming abundant, but what about the longer term? Here I will present the Norway 5-year results. The trial is an open-label, multi-center non-inferiority trial. Patients included had a degenerative spondylolisthesis and spinal stenosis with no improvement after conservative therapy of no less than 3 months. The diagnosis was MRI verified, and the spondylolisthesis had to be 3 millimeters or more on standing X-rays. Patients were included independent of the degree of slippage and dynamical instability. We did not include patients with lumbosacral scoliosis of more than 20 degrees, radicular pain due to extensive foraminal stenosis, previous surgery on the level of listhesis, or spondylolisthesis in more than one level. For the decompression group, a posterior decompression preserving the midline structures was mandatory. For the fusion group, an optional technique for posterior decompression was followed by pedicle screw instrumentation and bone grafting, with optional use of an intervertebral fusion device. A microscope or magnifying glass was mandatory in both treatment groups during decompression. The patients were followed for 5 years. The primary outcome was improvement of at least 30% on the ODI, defined as a successful outcome. Secondary outcomes included mean ODI, the Zurich claudication questionnaire, NRS in both leg and back pain, reoperation within 5 years, and the duration of surgery and hospital stay. 267 patients were enrolled in 16 departments in Norway, 134 assigned to decompression and 133 to fusion group. The x-axis here shows the difference in successful outcomes measured in percentage points. To the left, we have results favoring decompression, and to the right, we have a higher success rate in the fusion group. The non-inferiority margin was predefined to be 15 percentage points. In the analysis of the modified intention to treat set with multiple imputation, 63.2% met the primary outcome in the decompression group, while the results in the fusion group were 62.8%, a difference of 0.4 percentage points. In the per protocol analysis, the between group difference was 1.3 percentage points. Both the 95% confidence intervals in the primary analysis was within the predefined non-inferiority margin. There were also no difference in between the groups in the secondary outcomes for mean change in ODE, the Zurich claudication questionnaire in both symptom severity, physical function, and percentage satisfaction. We found no difference either in the NRS, leg, and back pain in both groups. The reoperation rate was 16.3% in the decompression group and 18.4% in the fusion group, a non-significant difference. There was a significantly shorter duration of surgery and hospital stay in the decompression group. The longer-term results in the Norway trial were similar to one of the previously published RCTs, but all the three trials showed significantly shorter duration of surgery and hospital stay when decompression alone was performed. This was an open label trial where the participants and the surgeons were not blinded. Only the data analyst was blinded for treatment allocation. There was also exclusion of certain patient groups, and the results can therefore not be generalizable to this. In this trial involving patients operated for spinal stenosis with degenerative spondylolisthesis, decompression alone was non-inferior or not worse than decompression with instrumented fusion, even after 5 years of follow-up. Special thanks to the patient surgeons and coordinators who contributed to this no-stain studies. Thank you for your attention.